My name's Heather Cox, and today I'm going to be going through a physical assessment with you from head to toe and talking to you about some key things and pieces that you need to remember in regards to it. One of the first things you need to do before you even go into the room is you need to review the patient's history and physical so that you're aware of what type of medical diagnosis and problems the patient has. For instance, if you went into the room when you did your physical assessment and they had an irregular heartbeat, you'd want to know if that was something they already had or if that's a new finding, so that you'd need to present that to the physician. Some other things you would need to do is make sure you have the appropriate equipment. And for instance, today, some things I'm going to be using certainly are my stethoscope and a pen light. If there are other things that you need to make sure that you have those things ready and take them into the room with you so that you're not having to leave and come back, so that you're doing well with your time. Other things you might want to know is if the patient has any restrictions on mobility. So if they're not going to be able to sit up with you or turn whenever you ask them, and you're certainly going to want to ask the patient those questions when you go into the room. But if you review their history and, for instance, you see that maybe they have osteoarthritis or osteoporosis, some of those things might cause limited mobility. So just make sure you review what you need to do before you go in, also including the purpose of the physical assessment. If this is just a normal physical assessment, for instance, shift, once a shift that you're going to be doing, these are the pieces that you would need to include every time you do it. If you go in and the patient starts complaining of pain or they're having trouble breathing or things change, you may have to stop your physical assessment and do more of a focused physical assessment instead of a head to toe, depending on what's going on with your patient. Okay? Now I'm going to show you what you should be doing when you enter the room and what you should do for every caring intervention for your patient or in the clinical setting. Whenever I come into the room, I want to make sure that I knock on the door because I want to allow for my patient's privacy. I want to foam in and out whenever I come into the room, and I want to foam in and out whenever I leave. And as I enter the room, I want to make sure and speak to my patient. Good morning, Mr. Brown. How are you doing today? And as the patient is speaking with me, I'm going to be noticing his speech patterns and if he is alert and oriented and if he's making sense. Mr. Brown, can you please tell me your name and date of birth? And while he's answering me with his name and date of birth, I want to make sure that I confirm on his ID bracelet that what he tells me matches. And I would have wanted to look that up before I came into the room as well. This way I confirm that I have the correct patient before I move on to do anything else. And then I want to go ahead and speak with Mr. Brown and explain to him what I'm doing. There are some key pieces that you need to do when you're interacting with your patient. Number one is acknowledge. I did that when I came into the room and I acknowledged Mr. Brown. Introduction, I want to go ahead and introduce myself. Mr. Brown, my name is Heather. I'm going to be your nurse today. Then I want to go ahead and do some explaining and duration of what I'm going to be doing with the patient. Mr. Brown, I'm going to be performing a physical assessment on you today, which is going to entail me using my stethoscope to kind of listen to your chest and your stomach. I'm going to be touching you in some places to make sure that you have good pulses and to make sure everything is going on and the way it is. I'll be assessing equipment while I'm in here to make sure your IV is functional, and I'll probably check your vital signs and things, for instance, your blood pressure and some things. So as part of the introduction process, I've acknowledged my patient, I've done an introduction of myself, I've given a duration for how long I'm going to be in here. Mr. Brown, this physical assessment will probably take me about 15 to 20 minutes. And then I've explained to him the procedure, and certainly before I leave the room, I will thank Mr. Brown. Whenever I'm doing the physical assessment with you, if there are things that you can't tolerate, make sure that you let me know if you're having pain, or if I'm having you breathe, too quickly. If you need me to stop, make sure you let me know that, Mr. Brown. So by addressing that with him, I've also let him know that, for his comfort, if he needs me to stop or go slower or whatever we need to do. At this point, I could go ahead and proceed on with his physical assessment. Whenever you first come in, you're going to want to observe your patient when you first enter the room. You want to see their general appearance and dress. You also want to observe their behavior. Is it appropriate for the situation? Whenever he's speaking to me, I need to make sure that his speech is appropriate and clear and understandable, as we said before. When I'm doing my observation, I also want to be looking for symmetry, okay? So for instance, when I'm observing, is his face symmetrical? Because if you have a droop on one side or the other, that could be a sign of neurologic impairment, potential stroke, or some of those kinds of things. I usually start off asking my patient some questions. Mr. Brown, can you tell me your date of birth? Where are you at right now? Can you tell me what brought you to the hospital? And some other psychosocial questions they like for us to ask: do you live alone? Where do you live? Do you use any community services? And that way you're getting some psychosocial patterns from him as far as whether he needs assistance and what's going on with him. And I'm also still observing, is he alert and oriented? To finish that up, you know, do you know where you're at? What is the year? Because I'm wanting to make sure that he's alert and oriented to person, place, and time. So continuing on with the observation, I would go ahead and move up here. And I always want to look or observe before I touch, which would involve inspection, the piece of the assessment. Once I'm done with that, then I could move on and do my palpation and touch, and then I would certainly auscultate or listen with my stethoscope after that. So as I'm coming up here with him, I'm going to be observing, and I'm going to start with his head. Mr. Brown, I'm going to start with your head first. I'm just going to be looking, and then I may touch you and I may listen to a few things, okay? So as I'm observing his head, and I'm making sure that everything looks clean, that his hair looks like it's appropriate, that it's not falling out, you know, it looks kept, you know, washed and clean and those kinds of things. He doesn't have any lice or any of those types of issues. I'm also going to observe his eyes. I'm going to look and make sure, you know, that his sclera and pupils and everything look fine. He's, you know, opening and closing his eyes as he should. Do they look symmetrical on both sides of the faces? I'm going to observe his nares or his nose here. Since he has a nasal cannula in, I'm going to remove the nasal cannula, and I would observe to make sure that there's no skin breakdown in the nares to make sure that he doesn't have any issues there. While I'm assessing this, I'm also going to follow the tubing back up and make sure, you know, that the level of oxygen that he is on is what is ordered. I would move on down and I would have him open his mouth and say, ah. I would be looking at his teeth to make sure everything looks fine, his dentition is good. I would look to make sure that his mucous membranes are pink and moist, that, you know, there's no loose teeth, no vomitus, that there's no issues there, okay? I'm also going to observe his ears and look for symmetry here. Now I'm going to turn the light off at this point, and I'm going to go ahead and shine a light in Mr. Brown's eyes. Mr. Brown, if you'll look straight ahead for me, I'm going to be shining a light in your eye. And I'm going to come from the side into his eye and back away. Whenever there's no light shining in his eyes, his pupils should be dilated. Once I shine the light in his eyes, they should constrict. That is a normal response. Then I'm going to move over to the other eye and shine it in and away and in and away. And what I'm looking for here is that his pupils are both equal and round, and that they react to the light when I shine them in. The last piece I'm going to test is accommodation. Mr. Brown, if you'll follow my pen light here, I'm going to bring it towards you, and if you'll just focus on it. And as I bring the pen light toward him, his eyes should converge and his pupils should constrict. And as I go away, they should go back to the normal place and dilate. And this takes the formal assessment of PERLA, which is pupils equal, round, react to light, and accommodation. I would now turn the lights back on, and I would continue on with my assessment. So I've now observed, I've inspected. If there are areas that I need to palpate on his head, I would have done that if I saw any abnormalities. I'm now going to move down to his neck. Mr. Brown, I'm going to palpate your carotid pulse at your neck, making sure you only do one at the time. So I would come over and I would palpate on the left side and make sure that it's strong and regular. And then I would move over to the right side and palpate. And again, strong and regular. I've now completed the head assessment, you know, which included all the way down to the neck. I'm going to move on with him, and I'm observing again before I touch. Observe for the chest rise and fall, making sure he doesn't have any respiratory effort or no use of intercostal muscles. I can also look down and check his arms out, and if he has an IV in place, I would observe and check it for the date and the time and the initials, the gauge of the IV. If he's connected to any IV fluid, I would now look up here and make sure that it's the appropriate fluid. What the rate is set at, is that the correct ordered rate? Does his IV site look patent? You know, is it dry and intact? Are there any issues there with the IV? If there's anything else going on here and that I needed to observe, does he have any lumps, bumps, or bruises or anything with his skin that I need to note as part of my assessment? As I've gone down, I usually come to the arms before I move to the chest. So I've done my observation. Now I want to go ahead and palpate. And typically when you come, you want to palpate your brachial arteries, and you want to do them bilaterally and simultaneously, checking for strength and regularity. Then I would move down to the radial pulse. Again, bilaterally and simultaneously, and are they strong and regular? I'm now going to move down to Mr. Brown's hand, and I'm going to check here for his capillary refill by compressing and releasing his nail beds. And they should blanch or turn pale, and then the color would return in less than 3 seconds for a normal capillary refill. I'm also going to give him my 2 fingers in both hands. Mr. Brown, if you can please squeeze my fingers here as hard as you can. And I'm going to have him do that both at the same time so I can check out his strength bilaterally at the same time. I would then have him move his arms, and I'm seeing if he can follow commands, and also looking for movement and strength of bilateral arms to confirm that he has no issues with that. I'm going to then move on, and if I haven't done his vital signs at this point, I'm going to be picking up pieces of them as we go through, but you need to remember that your vital signs entail your patient's temperature, and typically whenever you guys come in for your simulations and things, they may well be taped to the patient's forehead or chin, but normally for my patient, I would go ahead and I would either do, for instance, a tympanic or, orally or rectally. Your more accurate temperatures are either oral or rectal or maybe bladder, because those are your more central temperatures. To finish up your vital signs, you would have your pulse, and so you may have the vital sign machine that you're using, but once we get to heart sounds, I'm certainly going to count an apical pulse. I would be listening to his respirations. I would also do a blood pressure, and usually on your mannequins in the lab, you're going to have one arm or the other that works for your mannequin. On your patient, you need to know if there are any limitations, for an arm I can't use. For instance, if they had an AV shunt or a fistula or graft, then you would want to stay away from that arm. If this was a female patient and they had had a mastectomy, I would want to stay away from that side because of the risk of lymphedema. With this patient, you can see he's got his blood pressure cuff over here, so this would be the arm that I would use. So we've confirmed temperature, pulse, respiration, and blood pressure. You also need to go ahead and your respiratory rate, and also throw in here pain. I need to ask Mr. Brown, is he having any pain? And if he is, what is the site or location? Does anything you do make it better or worse? What's the intensity? And give me a range. And usually with an adult, you'll use a range of 0 to 10, 0 being the least and 10 the most. Depending on your patient's age, there may be some other ranges or things that you would need to use to address their pain and get a pain rating. The last thing we would need is a pulse oximeter reading on him, which would tell us, his breathing. And what's especially important to note is when you do a pulse oximetry, is your patient on room air or are they on oxygen? And Mr. Brown here is on 2 liters. So if I recorded his pulse ox as 97%, which is what the monitor is saying up here, I'd need to note that it was on 2 liters by nasal cannula, which is the equipment that he has on. So we've addressed his vital signs, and certainly I will, be doing some more as I'm going through. Mr. Brown, I'm going to go ahead and uncover your chest here for a minute, sir, and we're going to finish the assessment up here on the front portion. Normally you would keep your patient covered, but for you to be able to see anatomy, I'm pulling this down. So we would normally provide for privacy. This is this way so I can show you anatomy and physiology in here. So as we're doing again, I'm going to observe respiratory effort. Is he breathing evenly? Does he have any work of breathing? Does he look dyspneic? Is he having any issues? And he looks like he's doing fine here, okay? I'm also looking for lumps, bumps, and bruises if there's any problems here. If there's equipment, I would note that it's there and in place. For instance, if he had a cardiac monitor, is it in place? And he does not have one, but if he did, the leads would be here, and you'd want to make sure and get a rhythm strip. If he had a central venous line, it would probably be up here in the chest, the central venous catheter. If he had a PICC line, it would be down in his arm. I would want to perform most of the same assessments that I had done with the IV before. Is the dressing dry and intact? Is it patent? Is it dated time and initialed? Once I've observed, if there are things I need to palpate, then I would do this. And one thing I would want to palpate with him, since I'm going to listen to his heart sounds, I need to make sure that I find his intercostal spaces and make sure that I can find things in relation to his anatomy. So when you're going to go through and find your locations of your heart, you need to make sure that you can find your clavicle up here and your sternum, which goes straight down the chest. Because whenever you're finding your locations for your heart sounds, those are some of your major landmarks that you need to find. So once I've found my clavicle, I need to come and I need to find my first rib, and my first intercostal space, which is the space in between the rib, my second rib, and my second intercostal space. Once I found my second intercostal space, I'm now on the right sternal border. This is the first heart sound. Second intercostal space, right sternal border. This would be the aortic heart sound. I would now flip over across the other side of the chest to the second intercostal space, left sternal border, and this is my pulmonic sound. I'm now going to find my third rib, my third intercostal space, my fourth rib, my fourth intercostal space, again on the left sternal border, and this would now be, and a mnemonic to help you remember this is 8 to man, aortic, pulmonic, tricuspid. So this is my tricuspid heart sound. And then if I move on down and find the fifth rib and the fifth intercostal space, now I need to come down to mid-clavicular line. This now is my mitral or my atrial, okay? So this is the location of that heart sound. When I listen here, I need to listen for a full minute, and this is the apical heart rate that you will be counting. So I'm going to go through these for you, and at each of these other sites, the apical, the pulmonic, the tricuspid, you need to listen for at least lub-dub, which is 1 heart cycle. When I get down here to the mitral, I need to listen for a full minute because I'm going to be counting an apical pulse. So I'll now put my stethoscope in and I will show you. And if you have not warmed your stethoscope by this point, you would probably want to do that so that you don't put a cold stethoscope on Mr. Brown's skin. Okay, and so just remember in the apical place, you truly want to listen for a full minute to count your apical pulse. The next thing I'm going to do is I'm going to move over and listen to his breathing, okay? Whenever you listen to lung sounds, both anteriorly, which is the front part, and posteriorly, which is the back part of the chest, you need to make sure that you listen at least in 8 sites minimum on the front anteriorly and on the back posteriorly. And when you start, you need to start from the top and work your way down and go in a zigzag pattern. So I'm going to show you how you go through and listen to breath sounds anteriorly. And Mr. Brown, if you will please take a deep breath in and out every time you feel me move my stethoscope on your chest. If you also breathe with your mouth open, it helps me hear better. Now you need to tailor this to your patient's tolerance, because if your patient can't stand breathing in and out too frequently, you need to go a little bit slower. But you also need to make sure that when you're listening, you listen for a full inhalation and exhalation. All right, Mr. Brown, here we go. Okay, so I've listened for my 8 minimum spots on the anterior part of his chest. The other thing you have to remember is that Mr. Brown obviously is a man. If you have a lady and you have breast tissue, you're going to have to move around the breast tissue to be able to access potentially the apical pulse, and also to get around to listen to your breath sounds. So for instance, if the lady could take the gown and she could either hold her breast up with her hand, or for instance, you could hold her breast up with the hand, because in order to get to the apical or mitral area on a lady, you're going to have to be underneath the breast tissue, okay? Now, if we moved Mr. Brown so that we could do this posteriorly, I would then have him set up, and I would go through the same pattern of starting at the top, moving to the bottom, going from side to side, making sure that I do the 8 minimum sites. Also, whenever you're listening, you do not want to listen over the scapula because you will not hear lung sounds. So you start off in the top, come in so that you're listening over the middle of the back, and then go out for the next 2 spaces. You also want to make sure that you listen laterally to the lungs on both sides, because as you remember from your anatomy and physiology class, your right lung has 3 lobes, and if you don't listen laterally, you'll miss one of the sides. So when you're listening, you want to go through and do a zigzag pattern again, and I'm not going to put them in this time, but I'll just kind of show you. I'm going to listen to your sides here, Mr. Brown. So I would come to the top and hit to the side and hit to the side. So make sure you hit at least 3 positions on the lateral sides, making sure that you have a zigzag pattern and that you're listening for at least an inhalation and exhalation cycle. Whenever I had Mr. Brown set up, if he couldn't tolerate sitting up, I could also roll him to his side. Because not all patients can sit up. Maybe it makes them have pain. They can't tolerate sitting up for a long period of time. Whatever I'm doing, once I do get him to the side, I need to also, or when I sit him up, I need to inspect the posterior surfaces because I need to be aware if there's skin breakdown or if he's having any issues there. So for instance, if I would ask him to roll to his side at this point, I would assess his sacrum and coccyx area for any breakdown, if he had any edema or anything back there. I would also look down his legs at the back for breakdown and check his heels and make sure he doesn't have any skin breakdown on the heels. And if he's at risk for foot drop, we may put him elevated on a towel to keep him from having some skin breakdown and some of those kinds of things. Now that I've finished with his breath sounds and his heart sounds, I'm going to go ahead and pull his gown back up here. And as we had said before, you guys would keep him covered and listen underneath the gown to make sure that you provided for privacy. Another thing that I might want to do is have Mr. Brown to use his incentive spirometer at this point. If he doesn't know how to use it, I might provide patient education as applicable here. I would certainly want to be noting the amount that he reaches, and if this is more than what he's been doing. I might also go through and ask him, have you been having any coughing, Mr. Brown? And if he has, have you gotten any sputum up, and what color is it, and what does it look like? We've already moved down his arms, and we've gotten his pulses, and we've done his movement, and all of those kinds of things. So I'm now going to move on down, and I'm going to, Mr. Brown, I'm going to lift your gown up here, sir. And so for you guys, I would bare his stomach, because you're going to be able to see it, and then also keep any of the other areas covered so that you don't cause him any discomfort. Again here, when I move to the abdomen, I'm going to make sure that I observe first. I'm looking to see if he has any pulsations, if he has lumps, bumps, or bruises here. I'm also looking to see if he has any wounds or drains, and to make sure that, if the dressings are dry and intact and if there are any issues there. At this point, I would also ask Mr. Brown, when was the last time you had a bowel movement? And was that normal for you? Was it a normal bowel movement? And how often do you have bowel movements? Because I need to establish a pattern for him. I might also ask him, when was the last time that you urinated? And was that normal for you? What was the color, and was there any odor to it? If he had a Foley catheter, then certainly when it's the appropriate time, I would address if the Foley catheter is intact. If the securement device is there, I would address that it's hanging lower than him, what is the color and amount of the urine, and if there are any issues there, and make sure that you're providing Foley care, as per policy. If he had any other equipment here, for instance, if he had, a femoral catheter, I would note that it was dry and intact. What is his level of sensation, for instance, if he had an epidural cath whenever I had rolled his back. And remember, whenever you guys are starting out, your patient may or may not have all this equipment, and you may or may not have learned about all this equipment. So as you learn more advanced procedures, make sure that you throw in the equipment that's appropriate for your patient during your assessment. So I've observed his abdomen. I'm also going to ask him, is he having any tenderness? I'm going to note if there's any distension. When I do get to palpate, I'm going to see if he has any firmness. But with the abdomen, you have to remember that your physical assessment changes a little here, because you want to observe first, but I need to listen before I palpate, because if I palpate, it could manipulate the bowels, and it could change the normal bowel sounds my patient has. So I've observed. Now I'm going to auscultate, or listen with my stethoscope. When you start, you need to make sure that you start in the right lower quadrant. You need to move up to the right upper quadrant. You move over to the left upper quadrant, and then finally the left lower quadrant. You're going to hear more sounds over on this side of the abdomen, because this is where your large and small intestine are attaching, and you've got more sounds in the small intestine as it's working. You'll probably hear fewer sounds over on the left side because that is the end of your colon and where the stool would normally come out. Now, as you're listening, you want to make sure and note if the bowel sounds are normoactive. If they're less than the range your textbook tells you, and I think your range that our book gives us is 12 to 20, if they're less than that, in a minute, they would be considered hypoactive. If they're more than 20, they would be considered hyperactive. If you're going to say that the patient has absent bowel sounds, you really should listen for a minimum of 5 minutes. And sometimes people can have absent bowel sounds, especially if they come back from surgery and as a result of some of the anesthesia and some of those kinds of things. But it's important that you note bowel sounds. For instance, if your patient doesn't have them, then they might end up having something going on and they might need to be MPO or without things to eat or whatever. Some other things that you'd also want to note here, if your patient had a nasogastric tube, which runs from the nose to the stomach, or if they have a PEG tube, which is percutaneous endoscopic gastrostomy, which is put straight into the stomach. This is an alteration in your nutrition, and you need to make sure that, they're dry and intact. You would check placement as applicable for which of the ones that your patient has. You'd also need to know what diet type they're on. For instance, if they have a nasogastric tube, they may well be on suction. If your patient's on suction, you want to make sure you turn the suction off before you listen to the bowel sounds, otherwise you would be listening to the suction. If they have the gastrostomy tube or a feeding tube, they may be getting tube feedings, and you want to know the type of tube feeding, the amount, anything that's ordered for them. If your patient doesn't have these things, like the NG tube or the gastrostomy tube, you would want to assess what is their ordered diet, how are they tolerating their food, certainly their intake and output. But, always remember nutrition is part of your assessment. So we've made it through and done the inspection, and we've auscultated. Now we could come through and we could palpate very lightly. We never do deep palpation here with our patients. And we're checking to see if he has tenderness and firmness. We're also looking for distension here in this area. Mr. Brown, I'm going to cover you back up here a little bit and provide privacy as I move along. At this point, I would now move and check femoral pulses, both bilaterally and simultaneously, checking for strength and regularity. And as I said, if he had a femoral catheter, I would address that at this time, making sure it was dry and intact. If he had the Foley catheter, I would look here to make sure that it was intact and that the securement device was in place. Make sure he doesn't have any issues with it, ask if he has any pain or any of those kinds of things. I'm now going to pull his gown back down, and I'm going to pull his covers up and move down to the feet. I'm going to uncover your feet here for just a minute, Mr. Brown. I've already addressed his femoral pulses, so now I'm going to move to his popliteal. You may be able to feel them both bilaterally and simultaneously, but sometimes they're hard to find on patients. So if you're having a hard time, you may have to cup around with bilateral hands to find the popliteal. But you want to go ahead and do both legs because you should be feeling, bilaterally for everything that you're doing. I'm now going to move down to his feet. I'm going to finish up his pulses. So I'm going to come to bilateral feet and palpate for his dorsalis pedis. And then come to the inner ankles and find his posterior tibialis. And now I've finished checking his pulses bilaterally and simultaneously. I'm going to move on down to his toes and his nail beds. And again, I'm going to check for capillary refill here. I'm going to compress the nail bed. They should blanch or turn pale. As I let them go, the blood flow should return, which should make them turn pink or red again. And that should occur within less than 3 seconds. That's a normal capillary refill for my patient. I'm also going to check if I have not already addressed the heels. I need to make sure that there's no skin breakdown on either one. I'm also going to note the skin turgor in the legs. And what you may say instead of skin turgor might be, is there edema present or not? I would have also looked for that on the patient's arms. And the primary place to check for skin turgor is up on the patient's chest. Usually it's below the clavicle. You would pinch up and see if the skin returns to place. This is the best and most accurate place to check, but you also want to check on the arms. And then on the legs, you're just noting, is there edema? Okay? Because if the skin tints or stays up, then your patient may well be dehydrated. That could be a sign of it. We've looked at the legs. I'm also checking the back of the legs to make sure that there's no skin breakdown. I also could have done this if I'd rolled my patient to the side. I need to go ahead and check their movement of their legs. Mr. Brown, can you lift your right leg? And as he's doing this, I'm noting, is he following commands? Does he have full and equal movement? I would then have him do the same thing with the left leg. You may or may not observe your patient walking whenever you're doing this part of the physical assessment, but certainly throughout the day, you need to make sure that you know what the ordered activity for the patient is. And if they do get up and walk, per order, you need to note if their gait is steady and if they are able to bear weight, and also how they tolerate it. Do they have any shortness of breath or any pain with it? I'm going to move down to his feet, and I'm going to get him to do pedal pushes and pulls for me. So I'm going to push on his feet. Mr. Brown, can you push against my hands? And he needs to do that both bilaterally and simultaneously. I'm checking for strength. That was the pedal push. The pull is where he now pulls his toes towards his nose. Can you now pull your toes up towards your nose? And as he does that, I'm putting resistance against them, and I'm checking again here for strength and equality and those things. As I've moved down his legs, I would also want to note if he has TED hose or sequential compression devices on. Certainly as part of my skin assessment, I would want to make sure and take off the sequential compression devices and TED hose to assess to make sure he doesn't have any skin breakdown or that there aren't any issues there. If there was any equipment that I had missed in doing his assessment, I would want to make sure and go back and address this at this point. If I hadn't addressed his IV or his oxygen, if I hadn't done the patient teaching with him with the incentive spirometer, I could certainly go back and do that at this point. If there was a femoral catheter or any other things that he had going on, I would want to go back and address those things. If I hadn't done his vital signs when I first come into the room, I might want to do that. But typically you do those when you first go in to make sure that your patient is stable. Once I've completed my physical assessment, I'm now going to speak with Mr. Brown and thank him for letting me come in and do his physical assessment. I'm going to ask him if he has any needs before I leave the room, making sure that I have addressed that he is not in any pain, that he doesn't need to go to the bathroom, which may be called potty. I'm going to make sure that he has things in proximity, including his call bell. If he had a bedside table, I would want to make sure and pull that back over here. And then also making sure he is in the correct position or if he needs to be moved. So as long as it's not contraindicated on his orders, does he need to turn or does he need assistance? Do I need to get another pillow or any of those kinds of things? I also need to make sure and provide for safety. So when I walked into the room, I probably would have addressed safety, but I also need to address it whenever I leave the room. So I need to make sure that his bed is low, that his call bell is within reach, that he has the appropriate number of side rails up. If you have all 4 up while the patient is in the room, they can be considered a restraint, so you need to make sure that you have an order for that. Is the bed locked? So I need to make sure and move it, make sure it doesn't move, and check the apparatus to make sure it is locked. Make sure he doesn't need anything else before I leave. Again, thank him for his care. And as I leave, I need to make sure that I'm going to foam in and out. And I need to let him know when I'll be back and make sure that I do come back in the time frame or have somebody else come and let him know why I was not able to come back in that time frame. Thank you very much for paying attention, and I hope you'll have a successful physical assessment.